Hi, I'm Dr. Nicole Avard, Medical Director at Metluma. I've had 20 years experience in general practice. I currently have a recognition of extended skills in integrative medicine, and I founded Metluma with Georgie Drury because I was frustrated with giving levels of care of women that just couldn't access it effectively and efficiently.
Hi, I'm Georgie Drury, co-founder and CEO of Metluma. I've been working in the digital health space for 26 years, and I often joke that we still say digital health, but we no longer say digital banking, but that's where we're at with healthcare. So I've been very passionate about using technology to help improve our healthcare system. I'm really wanting to give women access to the right care at the right time. So in 2023, we actually received a government grant to build a feasibility and acceptability study on what we call a smart health community model. It's a management consulting model out of Deloitte, but I thought, I think this is of interest to the perimenopausal and menopausal community. So we did that feasibility and acceptability study. We had great results, and so Metluma has been commercial in market since the start of 2024.
The common symptoms I was seeing was fatigue, lack of energy, sleep disturbance, feeling overwhelmed, anxiety, depression, issues with cognition and worried if they had early onset dementia. And it's easy for GPs to put this down to stress and start something like an SSRI medication. But I think we need to be putting perimenopause and menopause and the impact of hormones on the table in these conversations. The tricky thing for GPs is that we're showing up in a system that's directed by time. We need a lot of time to unpack these symptoms, and in a world where to make money we need to be seeing patients every 6 to 8 minutes, it's difficult to dive into these symptoms and really explore in a holistic, patient-centred fashion how hormones could be impacting these symptoms that are coming in day on day. We also know that these symptoms are changing across the stages of their perimenopause and menopausal journey, and that can make it even more complex in identifying what has a hormonal play when you're sitting in front of a midlife woman.
Senator Waters.
Very much, Acting Deputy President, and I move the business of the Senate Notice of Motion number 2, standing in my name, and I'm really proud to stand and move for this inquiry today, and I acknowledge the support of the co-sponsor of this motion, Senator Marielle Smith. I'm so proud to be establishing, with the support of this chamber, a Senate inquiry into menopause and perimenopause to understand its health impacts and its economic impacts on women and people who menstruate, and the impacts on the broader economy. Now, menopause and perimenopause is not really spoken about much publicly. In fact, the first mention on Hansard of perimenopause is from me about a month ago. But we need to be speaking about these issues, and we need good policy to address the impacts that they're having on women individually, on workplaces, and on women's financial security in particular.
The Australian government has actually done something quite globally profound, that in 2024 they announced a Senate inquiry into perimenopause and menopause. They were in every city across Australia, and Dr. Nicole Avard, my co-founder, and I were actually fortunate to speak in the Sydney Senate inquiry, and we presented the problem of how technology can actually be part of the solution. So we were speaking about the future of LLMs and AI and how we can actually use technology to improve access to care and also help in a triage approach. The government's not ready for that right now, as we know in digital health. However, there were some great outcomes. We did see hormones get on the PBS, and we actually saw that there is the opportunity to have a longer consult for doctors with their patients. There was limitations to this, that telehealth was not included. And so, as we know, people need to access the right care at the right time, especially in regional and rural Australia. And so we do think there's the opportunity to move on what came out of the Senate inquiry, including additional models of care. I'm a big believer in co-designing solutions that are fit for purpose, not just for the clinicians, but also for the patients. So building on some research I'd already done in regards to remote monitoring of cancer patients and also a smart health community approach for gestational diabetes, we then had the thesis that both of those together, remote monitoring and also the smart health community, would be very important for busy perimenopausal women. So what we did is we ran 3 arms. The first arm was the digital-only arm. The second arm was the digital and a group coaching arm, and the third arm was a digital and a one-on-one coaching. So if you can imagine, what we've learnt is that there's a combination of all three that actually delivers better health outcomes. And what the findings was the increase in the control cure subscale. So a lot of women actually have a very lack of health literacy and a health understanding, including myself, which is one of the reasons why we founded this company. To get to 43, I've never heard of the word perimenopause, is quite an interesting place, and that's where a lot of women are actually at. A lot of perimenopausal symptoms are latent, and women don't know what they don't know. So in that co-design process, we then offered a group coaching model. So think of it as a modern-day mothers group. So you've got one doctor that can actually increase that health literacy across 8 to 10 women in a telehealth or a virtual setting. So it's all done on Teams. And then we have that access to individual one-on-one care. So we actually pride ourselves on a 60-minute appointment. So 45 minutes with a doctor and then a follow-up of that 15 minutes with a care coordinator or a nurse clinician to really put into practice what has been unpacked in that 45-minute consult. So that's really quite important for us. What we've then learned is that menopause is not one and done. Literally 95% of our patients need to come back and have a follow-up appointment. But during that time frame, if they've chosen to go on hormones or other medication, it's the ability to have asynchronous support, and we find the chat functionality is very, very important for women. So rather than thinking, I've got to take time off work, book an appointment, try and get in, sit in a waiting room, we can actually message my doctor at 9 o'clock at night when I'm finally thinking about myself for 5 minutes. And then we know that we've got that 48-hour return rate to get back to the patients to really help them understand what's going on. So we find that's a really important feature of our model of care. Obviously, we're not an urgent care clinic and we're not trying to be an urgent care clinic, but we're really helping women access that right care at the right time. But fundamentally, the UMA40 is that start of that journey so that not only the patient but the clinician can have a sense of what's actually going on, but also what's important to that patient, what do they wish to work on. We called the UMA40 partly because when we were unpacking what is perimenopause and menopause, globally there is not a standard, so we thought we need to sort of try somewhere. In the UK, some academics are reporting there's over 100 symptoms. When we sit down with our clinicians and the medical community, we're like, do you really want to know about all those 100 symptoms? That's a little bit overwhelming. So we unpacked and found 40 symptoms that we know our doctors feel comfortable in monitoring and also treating. So there are things that we can do for those 40 symptoms. They come across the physical symptoms, the emotional symptoms, but also the genital urinary symptoms. So when we have this benchmark, starting with the 40, and we're open to whether it needs to become 42 or we can drop it down to 39, but I think there's a starting point to say, let's start measuring the 40 symptoms for women from around 40 years of age. That then gives colour to clinicians, but it also helps us underpin the data. What we want to start doing is tracking that data and see what is the symptom load across these women. That then can inform policy, it can then inform the government of where they need to put more time and energy. So how can the symptoms of mental now get attached to the physical, and we then can unpack more mental health support for women.
The hypothesis for the collection of data was what are the actual symptoms that women are presenting with perimenopause and menopause across the stages of the perimenopause and menopause journey, because that's not very well documented as far as we could see. So we took the Green Climacteric Scale, which is a very old tool developed in 1974, and worked with Monash University to modernise the language around that and digitise it so it was easy to deliver to women. We then blended that with the MenOD, which is a specific screening tool for menopause depression, developed by Professor Jay Shirashi Kulkarni, again at Monash University. And we took those two scales, the Green Climacteric Scale, the MenOD, and digitalised them so it was an easy to access, easy reportable tool for women to ascertain what their symptom load is across the perimenopause and menopause journey. We then launched this in March of last year. This tool is called the UMA40. We distributed this through educational and awareness webinars into our clinical populations, and it was an easy tool that women could access to collect their UMA40 score.
We knew that the results of that collection of data would be incredibly important to help shape the future of healthcare in Australia, as also the world. We know that We cannot create change unless we have the data to support that. So underpinning the creation of the UMA40 was the ability to share that data, not only to inform policy, but to help clinicians identify what's presenting in front of them. We can see from our report, yes, there are hot flushes, but it's not the primary reason why women are presenting in to see their clinicians. And what we want to do is get ahead of that. So we want women to understand that they don't need to be in a heat before they take time off work to actually go and see a doctor.
The data was collected from March 2025 until March 2026, and in that time frame we had over 1,400 participants give us their data, and the report was launched in May of 2026.
We need solutions to start conversations and enable people to access care so that we don't go years being exhausted trying to muddle our way through this. Systems and structures in the medical world just can't support that at the moment. The report is so reflective of what I see walking through my door. Not once did we see the word hot flushes, right? It's sleep, it's mood, it's concentration. Over time, that erodes away at our personal confidence. We can then start to lose ourselves as who we are as a human being.
This app has been designed with the clinician in mind. It's primarily for general practitioners, as perimenopausal and menopausal women are presenting with a range of symptoms to general practitioners. However, it can also be used by pharmacists, physiotherapists, psychologists and nurses, both as a symptomatology burden tool and also as a referral tool. The report has shown that the menopause transition starts earlier than most women think. For example, stage explains symptoms better than age alone. Brain fog can start at 44, low libido peaked at 59, and sleep disturbance was common, but again peaking at the age of 64. The other really interesting fact was that women were arriving with significant burden. 75% were presenting with fatigue, 64% were presenting with poor concentration, low libido was significant in over 60% of women, and there were significant mental health symptoms such as forgetfulness and feeling overwhelmed. The third thing to think about is that we identified some red flag conditions, meaning that women need to access quickly, effectively and efficiently, and over 43% of women presented with at least one red flag. There are a number of factors here for the clinical community to be aware of. The first is that the stage of perimenopause and menopause is more important in determining symptoms than the age of perimenopause and menopause. Jump onto the UMA40 and use that with your patients so that they can be aware of what their symptom load is. It's a double win here. You can ascertain what their symptom load is and treat accordingly, and they can use it to advocate for themselves with other healthcare professionals in order to receive treatment that is efficient and effective.
What came out of the experience report is that perimenopause and menopause is not something that women are silently suffering at home. It is fundamentally impact their careers, their ability to work and their relationships. So we know that if we can help women understand these symptoms, then it will actually have really positive impact in other areas of their life. So this isn't just a healthcare burden, it's a society burden, it's an employment burden. When you're looking at Australia's agenda to increase productivity, let's start with helping midlife women because they are the backbone of our country. They are raising the children, they are at home running the families, they are looking after ageing care and parents, and so it's how can we help these women thrive in their midlife.